Good afternoon. Thank you for joining us for advanced echo teaching this week. It is none other than Professor McLean who will be talking to us today. We're very excited to have Prof here, as always. I probably don't need to really introduce you too much. If you're on this and you haven't heard of Prof, you've got a lot of other lectures to watch. So Prof, he's a cardiologist, he's an intensivist, he's an echo guru, and he knows a lot about pregnant women. I think that's probably about the best I can say about you, Prof. Over to you for the next 45 minutes or so.
Thank you, Sam. Thank you. The presentation I'm giving today is not strictly a critical care one, but as all of you know, from time to time we get these patients in the ICU. They're usually unheralded, they're often very sick, and it's interesting. It's a very interesting area that I've been involved with for many years now, most of it outside the ICU, but when they do come to ICU, it's good to have the combination of critical care experience and echocardiography. With pregnant women who have a cardiac problem, they or their obstetrician are concerned about whether they can handle having a baby. There's often an antenatal assessment, so I'll just deal with that quickly first to give you some idea of what the challenges are and what we may possibly face in the acute setting. The first thing to say is that although people get rather, how would you say, concerned about obstetrical cardiology, there are only a certain number of conditions. Some of them we fear because we feel we're out of our depth if we're feeling with Eisenmenger syndrome or tetralogy of Fallot, but you'll find after a while that just a certain number of conditions you come across, and these are the specific cardiac pathologies in the antenatal woman that you'd be very careful about. The congenital, as you see, there are ASDs, PDAs, coarctations, tetralogy, VSDs, and Eisenmenger syndrome. And on the hereditary side, hypertrophic cardiomyopathy, Marfan's, and a bicuspid aortic valve. As you are probably aware, it's a bicuspid aortic valve that is not uncommonly encountered. Fortunately, the other two are very uncommonly encountered. And on the congenital side, of course, the fortunate thing nowadays is most of these people come having the defect repaired as a young child. The other pathologies in the pregnant women are the valvular ones, and depending on which community you're in, there's varying numbers of rheumatic valvular disease. Cardiomyopathies are not that common, but they do exist. Some are pre-existing, others are de novo. And of course, there's always in the background the occasional patient with coronary artery disease, even in the age group of 30s normally, sometimes early 40s, and even though they're female rather than male, who have a higher incidence of ischemic heart disease. The main one that you get, however, are arrhythmias, and most of them, fortunately, are not a big deal. It's more of reassurance and usually some prophylactic therapy, but sometimes you are caught out with serious ventricular ectopic arrhythmias. This is quite an old paper. This is back in 1995, but I like it because, in fact, it's just a chart of when you encounter a particular person, how dangerous is the mortality risk. And you can see that mortality less than 1%, ASD, VSD, a patent ductus even. The other, what people get concerned about is tetralogy of Fallot, but if that is actually repaired as a child, your mortality in these women is less than 1%. Obviously, porcine valve, not uncommonly encountered, and mitral stenosis, if it's mild, is generally not a problem. Now, when you jump up to moderate mitral stenosis or mitral stenosis with atrial fibrillation, now you're jumping up to a mortality of 5 to 15% or 1 in 10. Which is a considerable mortality. Same for aortic stenosis, uncorrected tetralogy of Fallot, previous myocardial infarction, and Marfan syndrome with normal aorta. Now, of course, these figures are rather rubbery because it depends. For example, if you had a previous myocardial infarction, have you had imaging of your coronary arteries? Have you had correction done of any significant lesions? So it would depend on the background. It's just not the particular diagnosis itself. There are certain things that you really stay away from. If they've got pulmonary hypertension, and don't let any woman with Eisenmeinder's become pregnant. It's just terrible. Coarctation, if you've got complications there, and Marfan's, once you've got aortic involvement, they should be recommended as not having children. The dangers are just too high. So in everyday practice, congenital heart disease is uncommon and they normally come to you with the diagnosis. It's not as though you have to chase it. Ischemic heart disease, usually known about in advance, but occasionally it occurs during the pregnancy, which raises a few challenges in dealing with it. Valvular disease is not uncommonly encountered, particularly in certain populations out here in Western Sydney. I'd have to say the biggest populations we have would be the Polynesians, people from South Asia, and immigrants from South Asia. They're often diagnosed when they're young anyway, but they come along with their recognized aortic regurgitation or mitral stenosis, and of course the indigenous population. Arrhythmias, as I said, are common, usually benign, but don't underestimate them. They're often very troublesome for the pregnant woman. What is the risk in Australia if you're pregnant? What's the risk of dying? Well, you can see there's 16 maternal deaths per 100,000 women giving, 6 maternal deaths, I should say, per 100,000 women giving birth, which means over Australia is about 300 deliveries a year. In an institution like ours, our delivery basis is somewhere close to 5,000 deliveries on this campus, including the private and public. So we would expect in that instance to have a maternal death once every 3 years or so. Of course, maternal death carries an enormous amount of emotional, administrative and other complications with it. The other thing to say is a lot of the deaths are not directly related to the pregnancy, as we'll come on to. They might be related to being pregnant and dying. And I guess the second row there is the one that's very troublesome, is the number of deaths from suicide. Out of that 16, there were 4 from suicide. The other thing also is that cardiovascular is the highest number of deaths is from heart disease. Once over the years, as you can see, it's pretty much of a muchness. It's usually about an average of 6 deaths per 100,000 per annum. A lot of them are direct, which means it's the underlying cardiac condition that kills them. The indirect, it has an influence, but is not primarily responsible. This is the interesting chart, and this is over a 10-year period. You can see that, in fact, cardiovascular deaths top the chart. But more importantly is that if you go down 1, 2, 3, 4, 5 lines, the other one that we encounter a lot in the critical care setting is thromboembolism. So those two combines, cardiovascular and thromboembolism, you're talking over a 10-year period of approximately 35 deaths. Add an amniotic fluid embolus, which is also a critical care illness, then you can see that we're likely to encounter a number of these women in the intensive care unit. What about the timing of the deaths? When do they occur? Well, not surprisingly, many of them occur on the day of birth, particularly the direct ones. Something happens at the time of the delivery. It's often hard to reverse the abnormality, and that's when a lot of the deaths occur. But just keep in mind that a lot of the deaths actually occur postpartum, and in fact, more occur in the postpartum period than they do in the antenatal period. So you're not out of danger once you've delivered the baby, and often people see delivery of the baby as a panacea to everything, it cures everything, but it's not really. And particularly with things like eclampsia, you've really got to watch them very closely and treat them for some days afterwards. Rather than talk about statistics, I thought we should talk about a few ones that are of interest. This is a 21-year-old woman that came down from Parkes. She had marked dyspnea. She was 33 weeks pregnant. She had previous pregnancies and they appeared to have been lost, and it was hard to get the full history, but domestic violence played a role in the loss of these pregnancies. It's often difficult to get to the bottom of it all. But the important thing from the clinician's viewpoint was that she had congenital aortic stenosis diagnosed as a child. and it was both a subaortic membrane and aortic stenosis. And she'd had 3 sternotomies over her short life, 2001, 2004, the recent one in 2014. And these were mainly for the subaortic membrane abnormality. And as you can see, she had the membrane resected, then she had muscle removed, and she was of the belief she had significant aortic stenosis. Apart from dyspnea, her other symptoms were somewhat vague. We, of course, did a transthoracic, and this is the picture here. That's the picture of the aortic root in the top left-hand corner. You can see the valve there, the cusp separating, opening quite well. And I guess what you're looking for is the subaortic membrane. And I don't know whether people wish to comment at all.
Yeah, Prof, I don't see any subaortic membrane. It doesn't look like there's any significant flow acceleration around the septum leading into the LVOT. And the waveform looks like the continuous wave. Is that continuous?
Yeah.
Then it looks like a fixed obstruction rather than a dynamic obstruction.
Okay, fair enough. No, I agree. We couldn't see a membrane. We looked pretty hard. We were expecting to see one with the stream. But no matter how hard we looked, we couldn't find it.
Can I ask Emma to critically analyse the bottom right image, please?
I think that'd be great.
You have, so that there's aliasing of the signal,
Very nice.
and there are multiple ghosting gates that you can see there.
Very nice.
So that signal could be from not the one that you're thinking it is, it could be from the ones further up.
Very
So you
nice.
need to optimise it.
And so how would you get rid of the gates?
So I would, so you could bring, adjust the Nyquist limit to the scale, you would want to reduce that. And for the 2D image itself, reduce the depth of that. And the baseline is already optimised.
Do you think we'll ever get to a place where we'd be able to estimate the Vmax with pulse wave Doppler?
No.
Excellent. Question?
Well, yeah, there, Emma. What about the aortic regurgitations?
Yeah, I worried about that aortic regurg, and I wonder whether the VTI would be high on this signal because of the regurgitant volume that's coming back through, rather than stenosis. It's quite eccentric, and I'd want to look at that in more views to grade the severity. The aortic root looks dilated. I'd be worried about that as a potential mechanism for the
And she's greater than 26% there if you looked at the ratio on the M1. So we would call that moderate. Here's the next one. Here's another continuous wave across the aorta. Just another one to show that in fact her peak is 3.37 meters per second. And we kept chasing it, as you see down there. This is the pulse wave down here that showed she had a high, but once again, as you see, she's got more than one focus area there. She had a reasonable ejection fraction, 50%. Is this woman's dyspnea? What do you think we will do? Has she got severe aortic stenosis? Because the 2D didn't really show it. But she's got these very high velocities.
Well, how much of that is due to the high flow state? Because she's, what, 33 weeks?
So if you thought that, what would you do? She's sitting in front of you, you've got to treat her.
Well, it's abnormal, but some of that will be due to being in a high flow state. So if you're looking just at the peak velocity.
So the patient's there, the obstetrician says, can I deliver her safely? Do I have to send her off to the surgeon? How are you going to? There is one way of doing it, which I'll show you. The real question, and this is the real question, is that can you sort it out before they go for their delivery? Because the anaesthetist will say, can I? Everybody said I rushed to cesarean, like the cesarean is the answer to everything, and it's not. And the anaesthetist says, can I give her an epidural, can I give her a spinal? What was aortic stenosis? You can't. Etc. So there's all these questions that have to be answered, and your role in the situation is to help is to answer it so they can make the decisions on the grounds, on the basis of the cardiac pathology you identified. So what we did, in fact, is that we followed our, does anybody want to comment on that?
It looks the same as what you got when you were shooting through the aortic valve itself, but now you're looking down the aorta. So that would make me think that there's not true aortic stenosis.
Oh, you're quite right. You're getting the same velocity down the arch of the aorta, which means that you've got the bloods that are coming through the aortic valves come down the arch with the same velocity. And so you're quite right. It's the high flow state. But you can't guess it. You've got to identify it so you can tell. And I just said, let's go ahead and deliver her normally, and she delivered quite well. Also, her breathlessness was not due to the aortic valve disease, but everybody with that history, 3 sternotomies, her saying she's got aortic stenosis, she just gets loaded with it and everybody puts her on it. But in fact, the heart was fine. And when you go back and talk to the cardiologist up in Orange, who did her echo months earlier, she had exactly the same. No, sorry, she had a TOE a year before that showed there was no subaortic membrane there. So that was just one, and that was really just evaluation. But to give you the idea that once you're in pregnancy.
What was the cause of her breathlessness then? Did she have?
I can't remember, it wasn't that.
Did she have high pulmonary pressures?
I can't remember at the moment, I'll be honest. A lot of pregnant women are breathless, and this is the other thing. I don't say it unkindly. You're carrying a lot of extra weight. You slow down the breathlessness. Is it
There's
real,
no way
is it
you
not?
could say that kindly. I'm sorry.
Of course I can.
Makes you very
I'm very empathetic. Anyway, this is just a follow-up on her. She actually had a very good cardiac output, cardiac index of 4.1. There was no stenosis, high output. So it comes to the cardiac demands in pregnancy, and I guess this is all pretty basic to everybody, is that your plasma volume goes up 40% by the time you're at 24 weeks. Your cardiac output goes up on average 40% during pregnancy. Early in the pregnancy, mainly due to increased stroke volume, later in the pregnancy, heart rate. Blood pressure normally drops early in the pregnancy, and your heart size can increase by up to 30%. Having said that, I presume that was based on old chest x-rays as opposed to echo. I'm not too sure of the data there, but you just have to keep it in mind. And to give you some idea, to try and stop these patients coming to the ICU, you sit down and have a big round the table session deciding how you're going to deal. This is a particular patient, I can't remember the exact problem, to say exactly what you were going to do through the pregnancy. It might have been that same patient. Case 2, this is a woman that was transferred, 25-year-old, transferred from, once again, out west, pneumonia, rushed to us because they thought she was going to require intubation, and she was intubated. She may have to deliver early at 25 weeks. She was very dyspneic. She had a background of antiphospholipid syndrome. This was a chest x-ray when she arrived with the diagnosis of left-sided pneumonia. People happy with the diagnosis?
Could
Shaking
be
the head.
edema.
Anne-Marie, what is it, Anne-Marie?
Looks like pulmonary edema.
Why is it a pulmonary edema as opposed to, she was sent down as a pneumonia? Yes, the nature of it is diffuse. We've got juicy veins up the top.
It could be bleeding as well. It could be anything. It's consolidation.
So you're saying it could be anything? You're saying it's likely to be pulmonary edema.
It's an echo joke, it's totally pulmonary edema.
I looked at it and thought pulmonary edema. It's got to be pulmonary edema. And it was pulmonary edema, but this is her heart. So maybe somebody from the other end of the computer would like to comment on this.
This is Sid Agarwal from Darwin. I can try and comment. So this patient has got a restricted opening of the mitral valve leaflets, both anterior and posterior, and thickening of the tip. on the closer look, on the zoomed view, I'm not sure whether it's a vegetation or just a thickening of the tip of the mitral valve leaflets. On the color Doppler, there is eccentric jet of free vegetation and a gradient. On the Doppler, pulse wave Doppler, the mean gradient across the mitral valve is 9.83 millimeters of mercury. Probably the average is around 9, and it suggests it's probably a high gradient across the mitral valve. So left atrium looks bigger. The left ventricle, as such, looks kind of normal sized, contacting well, no regional valve motion abnormality. The RV is smaller than the left side, and the interatrial septum is deviated to the right. So probably she's got a increased size, area, and volume of the left atrium. So probably she's got a moderate to severe mitral stenosis, along with the thickening of the anterior mitral leaflet and mitral regurgitation.
Okay, fair enough. No, I agree. You look at that and think this woman is pulmonary, it's got to be pulmonary edema. Well, there's got to be an element of pulmonary edema. Just looking at those pictures alone, obviously we did more. This is just a little closer when we're trying. I don't think this probably adds much more to what you've said already. We're just trying to hone in on that mitral valve a little more. She's 25 weeks. And obviously, if we're trying to determine what the problem with the mitral valve is, this is just to give you some idea of the mitral regurgitant flow across the valve, a different view of the mitral regurg, the fact she's got a lot of B lines in the lungs. Anyway, so to take it further, we actually did a toe. Would you like to comment on this? Anyone?
Again, there is a restricted movement or opening of the mitral valve leaflets. It looks more of a thickening of the tip rather than the vegetation to me. The LV contractility looks normal to me.
Does anyone have any comment on the thickening of the mitral leaflets?
It's like romantic
Well,
carditis.
You know.
well, I guess there's a couple of things. You know, I guess what is the nature of this thickening? I mean, it is possible that this young woman has got mitral stenosis and has just declared herself later in pregnancy. The mitral valve area, as determined on one of those previous images, was 3.2 centimeters, so not particularly stenotic. The appearance, you know, the question has to be made whether it's kind of universally thickened or classically hockey sticked, and it's less classically hockey sticked. And she does have a history of antiphospholipid syndrome, which means that she could have something like Liebman-Sachs. So I guess the question is, does she have worsening congenital mitral stenosis from rheumatic heart disease? And there's a couple of factors against that. Or does she have another pathology which is concurrent to her pregnancy, which is perhaps related to her antiphospholipid, and whether or not, you know, this leans more towards something like a endocarditis or a Liebman-Sachs phenomena.
Yeah, very good.
Non-infective endocarditis.
Yeah, the interesting thing is the nature of those masses, and I guess this is where you're trying to hone in. They are abnormal masses in a person who's got an abnormal mitral valve, and it's kind of interesting. You're quite right. If you looked at just goes to show you have to look at a number of parameters. If you looked at the gradient across the mitral valve, you'd be thinking about moderate to severe mitral stenosis. But when you look at that, it's not at all. But if you were thinking, I mean, we see quite a bit of infective endocarditis. Looking at those, they did not look infectious to me, but I still believe it was endocarditis. They're homogeneous. They don't seem to have a stalk. They seem to be attached to both the anterior and the posterior mitral leaflet. So let's carry on, because whoever spoke last hit it on the head. Is that if it's not infective endocarditis, but you've got valvular lesions and you have a number of things there, and I know you all know this list. And the one I really want to talk about is Liebman-Sachs, because that is what it was. Now, it's Liebensack's endocarditis. And just to let you know that Liebensack's endocarditis is more common, even though it's not uncommon, it's more common in antiphospholipid syndrome than it is in lupus endocarditis, or lupus. Even though we always associate with SLE, it's much a higher rate in antiphospholipid syndrome. It's not named after these two guys here in the days where you could have something named after you. But it's very interesting for this woman because she's 25 weeks and you've got to do something about it because do you operate on them? And this is where it becomes a line of difference between infection and non-bacterial or morantic endocarditis. Because the morantic endocarditis are warty, and you could see that sort of warty, smooth nature to them. They're along the lines of this valve closure. The mitral is more affected than the aortic. They have a very high embolic risk. So what did we do? Oops. So what did we do? The reality was, if you look up the literature, there's no clear guidelines because it's such an uncommon situation. And if you put this woman on, if you operate on her and replace her valve, at 25 weeks pregnancy, then you're left with the difficulty of someone who's got a valve, who's got antiphospholipid syndrome, who requires anticoagulation. And so there are some approaches that suggest you should at least do it with conservative treatment first. Cut long story short, she actually had an acute delivery at 27 weeks. And we got her through her pregnancy with severe mitral regurgitation. She had the valve repaired 6 months postpartum. This is one of my favorites because I think it really shows the beauty of echo in the ICU setting. It's a 17-year-old woman who was 39 weeks pregnant, came into hospital because she's a little bit asymptomatic, a little bit symptomatic with dyspnea, but not too bad. But while she's on the antenatal ward, she was found to be increasingly hypoxic, and they did check the baby's heart rate and found that it was in fetal distress. She goes directly to the anaesthetic, to the operating theatres. The next thing we get a call from the anaesthetist to say, this woman's dying on us. Would we transfer her to a heart transplant centre ASAP? Which I thought that was pretty good. It was a sort of, don't stop it, go, just go directly there. And so they brought her over, they delivered the baby very quickly. They delivered her over to us, I remember it was 6 o'clock in the evening. She was hypoxic, she had sphinx frothy sputum coming up through the tube. You just couldn't get the oxygen into her. And so we did an echo the second that she arrived. And this was the echo. Any comments?
Rheumatic mitral stenosis with a very large atrium.
Yeah, she's got mitral stenosis. She got to 39 weeks, never been diagnosed in her life, got to 39 weeks pregnancy without anyone picking up she was dealing with such pathology, and basically collapsed on the last day, but mainly because of fetal distress. But of course, as soon as she went to theatre, was given fluid as well as an anaesthetic, it all fell apart. And you can see it's not only the mitral stenosis, but also a degree of regurgitation of very dilated LA. There's the classical M mode picture of mitral stenosis. There's the size of the left atrium to show that it's chronic. Candle
flame on the color Doppler. Yeah. Candle flame on the color Doppler.
Yeah. True. Of course, the other thing was that she had a good ejection fraction, and she had a pulmonary artery pressure on that one about, that's RV minus A of 41. So she had the diagnosis of severe mitral stenosis was made. 6 o'clock in the evening, we did 2 things. One is we put on a furosemide infusion. 2, I put on digoxin, because the one thing you fear with these patients is they go into atrial fibrillation, and that loss of the regular atrial input with each beat is devastating in these patients. And by the next morning, she was extubated, sitting up, holding a baby with her own mother next to her, 3 generations of women. She was smiling and happy. She was out of hospital in a few days, and she had the valve repaired at about 6 months again after everything has settled down. So once again, without that echo, there was just confusion. Any comments? Interrupt me along the way if you wish to.
She was Indigenous.
Pardon?
Indigenous. Indigenous. Was she Indigenous?
Yes, she was Indigenous. Yep. Sorry for asking to repeat it 3 times. Your soft voice, you like the soft voice. You're allowed to yell at me, you know? The 26-year-old, once again, another way of looking at it, elective C-section, G1, P1, shortness of breath during the procedure, hemodynamic decompensation, loss of output and CPR commenced. Was transferred to the ICU while there was CPR in her. Any comments?
Large right ventricle, septal bounce toward the left, likely to be a PE or amniotic fluid release.
Can you guys hear that?
Only partially.
Do you mind maybe just coming to shouting?
So large, this quick view showing large right ventricular outflow tract and the septal bounce to the left side, denoting pressure overload from the right ventricle. Likely in this context, possibly could be either an amniotic fluid embolism or rheumatic pulmonary embolism.
And lots of bubbles.
And the other thing to note there also, look at the left atrium. Small as can be, mitral valve hardly opening, and this is the classical situation where you have some obstruction, and you see with pulmonary embolus of some sort. This is her picture from the apical 4 chamber, obviously done during CPR as best we could. And this is the classical picture of a woman that halfway through a cesarean goes from being entirely stable to being completely unstable. She has an amniotic fluid embolus. It's hard to prove, but it seems to us that those floating white masses may be the embolus as opposed to bubbles of saline from injections, but it's hard to tell. You can see, and it's another instance, it shows a lot of things. One is that the right chambers can dilate up within half an hour. You've lost your right ventricular contraction virtually. You can see how you squash the left side out of existence. And unfortunately, despite all their efforts, this woman just was not able to be resuscitated. So amniotic fluid embolus, we fear it.
Did she go on to have a postpartum?
Can't remember actually. Can't remember. Probably because she would have also been a coroner's, and those were the days that coroners actually did postmortems, unlike now, because she was a death.
Death under anesthesia.
Yeah. So it wouldn't have been our call. Urgent call to recovery, 31-year-old. I think this might be yours, Sam. I think I might have stolen this. I don't know. Post-cesarean section, on the way to recovery, suddenly shortness of breath. If I got the right one. Obviously hemodynamically unstable, tachycardic, hypotensive, given a lot of fluid to bring the blood pressure up. She had preeclampsia, could reach some flu-like illness. And she has an echo done. Was it yours? Comments?
She's got like the clappers, and it's a bit hard to. My heart rate's 170.
Nice.
Can you see anything that's wrong?
I mean, there's a big bit of the left atrium that looks much, but I need to slow down and stuff. Like it's hard to comment on function when it's going on. That's all. Barely functions at all. It's hard to tell this.
Okay. It's pretty damn good, isn't it?
But it looks like it's thickening, like the interseptum and ambulatory walls look like they're thickening, but I need to slow the speed down.
Professor Ord, what do you think?
Well, I think it was someone who's looking like they're going at the clappers and the heart doesn't look like it's. I understand what you mean about it's not filling properly. Something doesn't look quite right. But again, it's the idea of seeing the whole heart. Don't don't forget of all the information that you got down there. What did Prof say at the beginning was one of the most common things? Rhythm, right? You know, the rapidity of that it came on.
Was she in SVT or?
No. So you've got to use everything. You know, it's not just about the echo, it's about the patient.
She's going at 170 beats a minute, which means that when we try and interpret the LV and other things, it's subjective. You can't put it into a formula, but just be a little careful when you're interpreting the LV, because you know, it's the contraction is so rapid. And basically, it wasn't an anatomical problem. The fact was she was an SVT. And so the answer was to convert her SVT, which we've done at the moment. And I think this is her a day or so later. Once that was converted, she was basically fine.
Yeah.
But the echo is very important, even when you go there and find out that it's not a structural echo thing, a mitral stenosis or a cardiomyopathy, then you can push it out of the way. Never underestimate the value. If I can agree that you can see some things that raise alarm bells, but there was really nothing big to say this explains it.
One of the benefits about this case for me, though, is also about knowing how to do echo, because she was going at a rate of 170 when we went around to see her in recovery, and she had probably that many anaesthetists standing around her as well. You know, everyone is saying this is an amniotic fluid embolus. You know, this is urgent stuff. You know, and you know, obviously we worry about the life-threatening things first. But it was the echo that helped show that the RV was not dilated, that the LV was just going like the clappers, and just a couple of echo images, and it was like, hang on, this is not an amniotic fluid embolus, this is something else. Have we done an ECG? You know, and it's often with these high-risk patients or these patients that everyone's scared about, we sometimes forget to do the simple things first.
And no pericardial effusion as well.
Yeah, nice. Yeah. So I think echo is really useful, just simply showing that the heart, as you said, was pretty good, and there was something else going on.
Well, it's a little like, I'm just digressing now, it's like the urgent tow that was done in theatre this morning that Emma did, is that the woman arrested when she was induced. Now, the echo showed straight away she had a huge akinetic segment in the left ventricle.
Right.
You know exactly what you're dealing with. It's likely she's had an acute infarct, she needed an acute angiogram. The echo changes everybody's, and often it's the intensivist that does it, because they're trying to break you. You pay your rent.
That's normal, don't worry. That's all the time. Nobody doesn't like the door closed.
Okay, so that was just, now where are we up to? I think I'm running out of cases shortly. What's this one here? Oh, this is a fascinating one, because she was 34 years of age, she first pregnancy, increasing dyspnea, comes in, as you can see, she is hypoxic, she's hypocarbic, and her heart rate's 125. That's a chest X-ray, which perhaps not much to comment on, except it doesn't look particularly abnormal. This is her echo. This is in the emergency department. We were called down to see her because they thought she'd require something done. They didn't know what. Anybody wish to comment?
So she has what looks here.
She's pregnant, 35 weeks. That's but come back to that one. That's a very important point.
What was her blood pressure again?
104 systolic. How does that help?
Well, if she had a massive PE, then you'd have to think about whether or not you try and retrieve the clot, if that was possible.
Now, see, that's interesting. What's
Because
a massive
now-
PE? You say
Hypotensive, but if her
that's
normal blood pressure was
that's the point I'm trying to make.
systolic,
You're
then
judging
you
as
might get away with fixate.
the point
Aren't
I'm
they
doing-
massive and submassive? And it relates to like arrest?
Exactly. People use the blood pressure, but it's misleading because that's a massive PE. I don't care what the blood pressure is. You don't have changes like that in a 35-year-old woman unless you've got a massive PE. So blood pressure, play around with your life, go to the reality with this woman is that she deteriorates, she's going to die on you. And as you can see already, her RV minus RA pressures alone at 55, and that's before we have the CVP. She's got severe pulmonary hypertension, and it has to be a PE. Well, the most 95% certain it's PE. It could be something else, I guess. So what do you do? Well, it was fascinating because we decided not to thrombolyze her because of the danger to the baby. But we were very nervous, so in the ICU, we set up the room with thrombolytic therapy on hand. So if she deteriorated, her life came first, we would thrombolyze her. In the meantime, we put her on a heparin infusion. Then we rang in our radiology college to say, well, let's confirm the diagnosis. And the radiologist said, sure, we can do a CTPA. He said, you do realize, of course, by doing a CTPA that you increase the risk of breast cancer by, I forget the number, but a considerable amount. He said, because you're doing it at a time when she has the most glandular growth in her breasts. And he said, we can do it, but you've got to tell her that you'll increase the risk of breast cancer by whatever the percentage was, which was not insignificant. So we said, oh, well, we don't need that then really. We'll go for a VQ scan. And nuclear physician said, yeah, we can do a VQ scan. No, that won't affect the breast. But by the way, the baby will be irradiated. So we said, right, well, she's stable at the moment. So do you have to do anything else? Or do you make it purely on the diagnosis on it?
It's definitely a PE.
That was our thing, definitely a PA. So we monitored her for 2 weeks in the ICU until things gradually settled. She had next to her bed thrombolytic therapy. She had a delivery tray for the baby, and all teams were ready to go any time of day or night. Anyway, it all settled down. She was going to go for a normal vaginal delivery, but they found she had large uterine fibroids, so she was delivered by cesarean section. And after she left, she showered the ICU with many, many presents. So the point to be made is that there was the echocardiogram that really ran the whole thing. And at least we think now she got out of hospital with a healthy baby. She hasn't got an increased risk of breast cancer. We didn't have to deliver radioactive therapy to the baby.
I'm just going to add that she's also got a 60-60 sign, probably being pretty useful there as well. Do you mind if I just go back one?
Yep.
Having a look at a TRV max of 55, and I bet the pulmonary acceleration time was super fast. She probably had a flying W sign. With that looking heart, it's got to be acute hypertension that's come on there. As you said, acute significant hypertension.
Yeah.
And it's got to be PE.
Yeah.
Did you have any further follow-up later?
Yeah, I followed up.
Any comeback tension?
No, at all. Her echo, by the time, shortly after delivery, we repeated the echo and everything had gone back to normal. Including, right heart, pulmonary pressures, all fine. Yeah.
Can I make a non-echo comment?
No, what are you talking about? Can't have non-echo comments.
I was just going to say that exposure in a VQ scan can be limited by catheterizing the woman and stopping the pooling in the bladder, which is something that's been described in the literature.
Wow.
And there was a review a year or two back that looked at thrombolytics in pregnancy that found no increase above the baseline risk, even at full dose thrombolysis.
I saw that too, yes.
Yeah.
The other thing you could do is just do a perfusion only phase of the VQ, because you don't need the ventilation phase, because you're assuming that her lungs are going to be otherwise normal because she's young, shouldn't have any structural lung disease.
Yeah.
So you find a radiologist that will just do a perfusion only phase, or a nuclear medicine physician.
Yeah, we used to do that, just do the perfusion stage and not do the ventilation.
Great.
Would you do catheter-directed therapy with her now? Obviously, that would come with some radiation cost, but you'd get a direct answer as opposed to her crashing at 2 a.m. and someone having to make the call on thrombolysis and possibly a crash Caesar.
What's the radiation difference between a CT scan and doing catheter-directed imaging? That's with the...
Depends on the operator.
Yeah, sure.
Yeah, it depends how confident they're feeling. You need to get a few shots to know where your clot is. And then if you've got a semi-experienced operator that's happy to thread the catheter up. I mean, you'd save a fair amount of radiation from doing it that way, but you'd save her life potentially more readily than lysing her and losing the thickness.
I'm a little old school, I just thrombolyze them.
Kylie, did you want to ask a question? Sorry, I've just seen your hand up. Was that this case or a different one?
Yes, this is this case. I've had one myself, pretty similar, although a little bit worse. And I always canvass for options in this particular case because it's a great one for discussion. And two other options that have been recommended in my case, which was a little sicker, was one is low dose thrombolysis, and the second was consideration of putting a patient like this on ECMO pre-Caesar. I know not for this particular patient, but when you do a cesarean section, if you have pelvic clot, when you take the baby out, you remove the back pressure on the clots, and so you are a little bit more prone to further thromboembolus. The previous case where you discussed how the patient arrested just in middle of the cesarean made me think of it. And so not this particular case here now, it was less sick, but in the one that I had, I would seriously consider those other two options.
Good thinking. Good thinking.
Thanks, Kylie.
Yeah. What else?
So Kylie, what did you do?
Look, we're a peripheral hospital, and so all we did was ask for help. The big hospital, because the baby was actually not doing well, transfer her urgently. They intubated her. They did a cesarean section, whereupon she arrested for 60 minutes, received CPR. They got the ECMO team in. She got put on ECMO, but she didn't survive. And neither did the baby. It was a dreadful case that we had a few years back. And it's always haunted me as to how else we should have done it. So I periodically ask.
And you raised another interesting thing there, which was the baby wasn't doing well, so she was transferred. Is that there is quite an ethical question that comes into all of this, is that when do you decide that the mother's life is more important and you're going to go all out to save the mother's life, even though you know you may be decreasing the chances of a successful baby? And fortunately, it doesn't arise that often, but sometimes it does. I don't have any qualms myself, because the mother's life always comes first. And you don't really want to be pushed into making that decision, but sometimes it is that you've got to decide you can't win on both fronts. Are you going to try and win on at least one? It's
And
interesting
even
to
more
say, put your lady.
complicated.
I find it interesting to say, put your lady on ECMO. For those of us who don't have an ECMO service, it always seems like a panacea. But when you follow up what happens to a lot of these patients, I think we're more, how would you say, influenced by the fancy technology than the yield that they have sometimes. But that's my prejudice coming in. Yep. Okay, moving on. What's our next case? Yes, so we can't talk about it unless we talk about pericardium cardiomyopathy. Just to give you some idea about pericardium cardiomyopathy, the fortunate thing, although we all fear it, people talk about it, it is really uncommon. We would get maybe one or two cases, at most per year at the PN, and whereas as I said earlier, we have about up to 5,000 deliveries. But they are really an interesting and dramatically difficult group to deal with. And just seen on the left side here, this woman presented postpartum. And you can see when I took this echo at 6 weeks, you can see that this woman is very severely affected with an ejection fraction. You'd be lucky if you got 15% out of that. Yet, on the other hand, as one who follows up a number of these patients, this is a woman who was 25 years postpartum. And as you can see, she's never gone back to a normal left ventricle with an ejection fraction of 55 to 70%. But she certainly has had a normal life and really has not been too troubled, and keeps on her little dose of ACE inhibitor. and a snippet of beta blocker, and she's led a normal life and not been troubled by it. And that's the reality of postpartum cardiomyopathy, is that it's a very curious beast. And as I said, it's a rare form of cardiac failure, first described by Ritchie in Edinburgh in mid-1800s. The incidence is pretty hard to figure out in your own community, because if you look at the US data, it's 1 in 3 to 5,000 births. But if you look at the South African data, particularly the Black population, you'll find that it's much higher. And so the question comes in, is it related to antenatal care? Is it related to other things? It's hard to know. But less than 1% of all cardiovascular events related to pregnancy are peripartum cardiomyopathy. So it does occur, but unlike the anaesthetists who want to rush every second person who decompensates off for a heart transplant, it is very rare. The important thing is, how do you define it? And this becomes difficult. The last lady I saw, who they was said to have a peripartum cardiomyopathy, presented at 32 weeks gestation with an ejection fraction around about 35 to 40%. But you can see that, in fact, if you looked at the strict criteria, she's not peripartum because it's the last month of pregnancy up until 5 months postpartum. You know, but on the other hand, who are the arbitrators who decide what are the strict criteria for peripartum cardiomyopathy? So this other young lady is, I assume that she might have had some pre-existing cardiomyopathy that just came to light then. But ironically, although it was down to 40% for a year postpartum, now after a year it's gone back to normal. So is it normal? I don't know. Was it postpartum? Who knows? The important thing is that you've got to have an absence of a demonstrable etiology for heart failure, some other cause, previous cardiomyopathy, ischemic heart disease, antiphospholipid syndrome or something. And as you can see there in the strict definition, you don't have any demonstrable heart disease before the last month of pregnancy. So that's before 36 weeks. I should say before delivery, that is. And ejection fraction less than 45% is the cutoff point. You can see that if you look at the number of patients, then most of them occur in the first month after delivery or at the time of delivery, or come to light at the time of delivery. But some don't present until second, third, or fourth, or fifth month. So keep your eyes open if someone comes along to your breath. It's 3 months after having a baby.
What for the pathology of the mind?
Pathology.
What the
The direct answer is I don't know, and notice it. Does anyone else? There's a number of purported etiologies going from endothelial dysfunction to hormonal dysfunction, and one of the treatments, in fact, is bromocriptine. And some of the patients would use oral bromocriptine. There's some good evidence from a woman called Siwa in South Africa who's done a lot of this work, and they swear by the fact you reduce the level of LV impairment by adding bromocriptine 5 milligrams per year. I've used it on about 3 patients. On an anecdotal level, I think it's useful, helpful. If you're looking for hard data, it's hard to come by. Other causes, people look and don't know. There's some genetic work to suggest there's a genetic component. There's all those other things come into it. I just might talk about a patient I'm going to put a photograph in, is young Chantal Kyling, you may recall.
Right.
I saw her a month ago. This woman had a antiphospholipid syndrome and ejection fraction of 35 to 40%. Is now 4 years postpartum. Asked me 2 months ago, should she consider having another pregnancy? I said, well, look, I won't say no, but you really have to have your antiphospholipid syndrome under strict control. You talk to the immunologist. She comes to see me last week and says, oh, by the way, I am pregnant. Oh, okay. But peripartum cardiomyopathy is the interesting one, is that there's a lot of work to say, well, if your ejection fraction goes back to normal within a few months, 6 months, then in fact you can be running out of time. If we're getting back to 6 months, you're getting back to normal, then you can probably do it. If it's certainly less than 35 or 40%, you shouldn't have another baby. Between 35, 40% and 55%, you discuss with the woman about the risk versus the benefits, and you usually work your way through it. But a significant number of women do often like to have a second baby. I guess you are a little more switched on knowing they've had it before, so you're very careful when treating them.
Do you advise them not to breastfeed if there's a hormonal and anecdotally bromocriptine works?
There's a what?
If bromocriptine works anecdotally, do you ask them not to breastfeed?
Haven't had that discussion. But you raise a good point. Of course, if you put them on bromocriptine, these women, they can't breastfeed.
No, so you would think
And
maybe
that's
breastfeeding is better.
and some women, breastfeeding is very important, and that's another, part of the decision making you have to discuss with them. And it's not like it's really strongly proven therapy, so you can't say you must have this. But the biggest difference about pericardium cardiomyopathies nowadays is very, very few go for transplant. It's mainly due to the treatment. In my opinion, having dealt with a number of these women over the years, it's the beta blockers. It's the beta blockers that have turned these women around. Obviously, you had ACE inhibitors and spironolactone and all that.
And Prof, sorry about the question. If they recover completely, would they be at risk of recurrence with the next pregnancy?
There'll be what? So
If they recover completely, would they be at risk of recurrence with the next pregnancy?
The data suggests possibly, but generally not. And but the data is very scratchy. Yeah, I mean, how do you get a series?
What's your favourite beta blocker?
And these patients carbidopa. It's stood the test of time. It's been good for years. There are others, but I like carbidopa. It's turned things around since the year 2000, and it still works really well. You've got to titrate it properly and push it up really high. Don't sit around with your 6.25. You've got to push it up
25.
12.5, 25, 50 if you can, they tolerate. This is my last one because this is was a little bit of a sobering one for me. 17-year-old with palpitations. I've been around a while, but I saw her at 17. And that was quite a while ago. She had a lot of SVT. She had a radiofrequency ablation. Good result. She was pregnant in her early 20s. Got her through a pregnancy, seemed to be all right. Continuing cardiac symptoms on and off. And then she came back to see me in her early 30s and she was complaining about breathlessness. And we did an echo, which is not playing. What a shame. Yeah, well, this one's playing. Hopefully this one's playing. Would you like to comment? Anyway.
Is that non-compaction?
Oh, bloody hell. Who took all that excitement away?
Nicely done, Joel.
Yeah, it's that kind of apical transgastric. It looks very worrisome. It looks very abnormal, that tissue. You obviously can't see it in your parasternal long axis that doesn't play, but that's that second loop that is playing, and even what looks like even further down on the third loop that's now playing, that's grossly abnormal myocardium. And I guess given the early onset of symptoms in a younger patient and that very peculiar appearance of the myocardium, it's kind of that thing. I mean, as I understand it, non-compaction is exceptionally rare, except for when you're sitting an echo exam, when it's almost always prevalent.
Yeah, quite right. Now, in fact, the only excuse I've got with this woman is we did echoes when she was 17, and I'm talking like she's now 40, so I'm talking over 20 years ago. And non-compaction didn't exist then, so it's a diagnosis. So that's the only. But as time went on, you've got to ask, why does the left ventricle drop, ejection fraction drop off? And of course, that's the classical thing in these people, is that not only do you have the changes to the apex, but they go from having a normal ejection fraction to gradually winding down. And this woman was not only echo, I went on with a cardiac MRI after this, that they have all these diagnostic criteria, as you're probably aware, because anyone with thickened walls get called it. But you've got to look at two things. You've got to look at the channels between the fibers, and with the MRI, you can see the pattern of the fibers, which is totally distorted. And she had non-compaction cardiomyopathy, and as a result of that, not only did we treat her for her impaired LVEF, but put in defibrillator as well, because these people have sudden death. You'll notice the interesting thing on the echoes there, it's pre-X, pre-X, and pre-X. It's because at this stage, she said she was getting breathless with exercise. I thought, oh, well, we'll just do an exercise test. But we didn't, we actually just did the exam prior to the exercise test and noticed then that what the pathology was. So you can see she's got a dilated left ventricle already at 62 millimeters. And as you pointed out already, she's got the classical features of non-compaction cardiomyopathy. So I think my last slide is, for the intensivist pregnancy and echo is always keep an open mind, because like a couple of cases were presented today, you go in looking for something, A, you don't find it, or B, you find something completely different, and just perform an echo. Don't mess around, just get an echo done anytime, day or night, as soon as the woman with the pregnant woman with a complication, or the immediate postpartum woman ends up in your caring hands, just do an echo, because in fact it gives you so much information. And that's the end of my talk.
Thank you very, very much, Prof. That was absolutely sensational as always. Thank you very much. Were there any questions for Prof? We've kind of been shouting them at you all the way. I've got a quick question, if I may. So you're saying perform these echoes immediately, and obviously I guess it's the question about follow-up for these guys. So you're obviously seeing these guys multiple times down the track. Is it common for you to see these abnormalities persist, or is it relatively uncommon?
It depends, and some do persist. And in fact, pericardium cardiomyopathy is a good one, is that when you see the woman, you can tell that this is going to take 2 years before we can tell you whether there's going to be considered reasonable recovery of your ventricle. You've got to tell them from the outset, this is not a quick fix, because it does take time. And you'll be surprised how many come back. That one I showed you that was 6 weeks postpartum, that barely contracted at all, she ended up with a normal LV. So you've got to do two things. One, warn them that it might not come back to normal. At the same time, give them a certain amount of optimism that with the drugs we have today, for many patients, they improve. Valves are a different thing, because valves, you've got the challenge of deciding, when do I move? When do I send them to the surgeon? You can send them to the surgeon anytime the surgeon will operate. That's what surgeons do. But particularly for a woman who's had a baby, you want things to settle down and get them over the postpartum period. They've got a new baby at home. And if you get by on medication, then they can go for surgery when things are a lot more settled. And as you notice, a couple I've mentioned, they went to 6 months, which is, I think, quite a good time. Others, you just got to play it by ear in terms of when you send them for surgery, if they need surgery. So the answer is, I think one of the things we don't do well is that these patients fall between in the gaps between the specialties. The obstetrician is afraid of heart. A lot of cardiologists don't want to do it with obstetrical cardiology. The intensivists might want to follow up on, post-ICU stress or something, but they don't deal with actual specific clinical problems. I'm being in a fortunate situation that I sort of cover both, but I do see a lot of these women, if they are followed up, often have to end up going from home to a specialist clinic in the middle of the city. And that in turn switches them off over time.
Yeah. Any data particular for the pericardium cardiomyopathy on levosimendan?
Oh yeah, I think levo is really good.
So it can shorten the period and have early recovery?
Yeah.
No, they're all just saying thanks.
No. Is it biventricular? Is it like a stress cardiomyopathy? Is it diastolic systolic and biventricular?
I have to be honest, so generally LV. Let's put it this way, there's no doubt RV involvement, but it doesn't appear to be a major problem, it's the LV. Once you've got significant LV dysfunction, you're going to have a degree of diastolic. I don't really measure it, to be honest.
Prof, thank you very much. That's probably time. Really appreciate your talk today. It was absolutely fantastic. Thank you very, very much indeed.
Thanks, Dan. Thank you,
See you later, guys. See you next week.
Thanks, bro. Thank you so much.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.